Well, hello, and welcome to Dear Healthcare Provider, the podcast where patients, providers, and policymakers meet to have purposeful conversations about health and the issues that impact access to care and health outcomes. We are so excited to welcome Dr. Fatima Cody Stanford. Dr. Stanford is an associate professor of medicine and pediatrics who practices and teaches at Massachusetts General Hospital, Harvard Medical School, as one of the first fellowship-trained obesity medicine physicians worldwide. She is among the most highly cited obesity medicine physician scientists with over 200 peer-reviewed publications. Stanford has conducted 1,200 media interviews, including with the New York Times, USA Today, Time, U.S. News and World Report, Glamour, and NPR. In 2023, Stanford appeared on 60 Minutes with Leslie Stahl, stating obesity is a chronic disease and that there is physician bias against those with excess weight. In an interview with Deborah Roberts on addressing weight stigma, Dr. Stanford advocates eliminating bias towards those with higher weights. Oprah Winfrey interviewed Dr. Stanford as an obesity expert for her The Life You Want class, The State of the Weight, on Oprah Daily. In this interview, she teaches about the science of obesity as a chronic disease. In an interview with Sanjay Gupta for his CNN Chasing Life podcast, she coined the term street corner medicine to refer to the assumption that people judge people based on their size. They assume that heavier people are unhealthy and leaner people are healthy without investigating whether this is factual by evaluating metabolic health parameters such as blood pressure, cholesterol, liver function tests, blood sugar, etc. And I could go on and on and on about Miss Fatima Cody Stanford, and I have been a fangirl fave forever and ever and ever, and I'm so honored to have her on my first podcast show in this first season of Dear Healthcare Provider. I am more than my BMI. Welcome, Dr. Stanford. Thank you so much for being here. Yes,
Thanks so much
yes.
for having me here. It's a delight to be here.
Yes, thank you so much. But before we get started, I always want to start this show on a positive note. So I'm just going to ask you a fun question. And the fun question is, what brings you joy and makes you smile?
Oh, so many things. I'm going to use a lot of F words. You guys happen to see that my first name begins with F. But the things that bring me joy happen to start with F. So my faith is a major source of joy for me. I start my day with scripture, and that's what starts my day. The next thing that starts after the F is fitness. So fitness is a huge part of my things that bring me joy. My husband always wonders, how do you get up and work out that early, and why do you? My husband has been with me as my partner for almost 30 years. Actually, we would have been together for 30 years next week. In terms of how long we've been together, we've been married for 23 years coming up very soon. And so my time with him is a lot. Family, right? Family is a huge part of what brings me joy. My family is who I spend my time with, no matter where I am in the country, wherever I am in the world. I spend time speaking with my husband, my parents, my sister, and just my family brings me a lot of joy. So what are those F words? I guess my faith, my family, my fitness, those are the things that bring me a lot of joy.
Oh, I love that. I love that. And it's so fitting for you because I guess you and I have known each other now for about 2 years. And I was so excited because
longer than that now.
I think so. I think so. Yeah. You reached out to me on LinkedIn, and I was like a little schoolgirl. You don't even know this. I was like, oh my God, Dr. Fatima Cody Stanford sent me a note on LinkedIn. I was smitten ever since. So anyway, and so it was just so wonderful. So I think it's so fitting. So thank you for sharing that. But now we'll jump right in. And so, this season is focused on weight bias, as you know, and I just think you're the perfect person to talk about this because I know you have dedicated your life to advocating for folks living with obesity, just like myself, and the millions of other people who live with this disease. And so I'm going to ask you a few questions, and we're going to talk about this, and we're going to dive deep. So I want this show to always be a place where people can get good education, sound information, and I know you are going to give it to us straight, right? So, Dr. Stanford.
Definitely.
I know you will. So can you talk to our audience about the complexities of the historical use of BMI in healthcare and its implications in the treatment of those living with the disease of obesity? Is BMI a reliable indicator of good health? And if not, what are reliable indicators of optimal health?
So yes, let's dive in. Let's go to this historical use of BMI and where is BMI derived from, and why I have problems with using BMI as a solo indicator of health. So let's take us back to the 1800s. I want you guys to recognize we are in 2024. So let's go back to the 1800s and let's talk about Adolphe Quetelet. Adolphe Quetelet was a Belgian statistician who sought to determine what was considered to be normal weight status for Belgium soldiers at the time. What was considered to be normal weight status for Belgium soldiers? I think if we look at the two of us on the screen, or think of any of us, I don't know many Belgium soldiers walking around right now that we need to determine what's considered normal for them. But I can think that if we're looking at most of us are Belgium soldiers. And this became the Quetelet index, which became the basis of determining what was normal for them at the time. It also became the basis for eugenics, okay? Eugenics, which then Adolf Hitler, maybe you guys have thoughts about Adolf Hitler, but Adolf Hitler used this to determine what was considered normal. And normalizing populations also used it to demonize certain groups. If you were not within a certain racial ethnic group, for example, you were not considered to be normal. Not within a certain size, you were not considered normal, for example. And this was the basis for a lot of what he used to justify Nazi Germany. So I'll let you guys decide if that was a good moment in our history and time. So that's the basis for the initial Quetelet index back in the 1800s. Let's move over to the 1930s. I think we agree that we're beyond that also, but in the 1930s, the Metropolitan Life Insurance Company decided to determine what was considered to be normal for insurability for mostly white men and women by the Metropolitan Life Insurance Company, hence the term morbid as it relates to obesity. Now, I want you to think about this term morbid as it relates to obesity. We don't use morbid to explain any other disease process, but a lot of diseases can kill people, right? So let's think of some of them. COVID-19 killed a lot of people, right? Heart disease kills a lot of people every day. Strokes kill a lot of people. Cancer kills a lot of people, but we don't call it morbid cancer. We don't call it morbid heart disease. We don't call it morbid COVID-19, but somehow morbid obesity became a thing. And that became because it became from these actuarial tables, right? These actuarial tables that sought to determine what was your risk for dying based upon your size, right? But also, it wasn't really looking at people, for example, that were descendants of enslaved, like people like me or like you, because that's not who the Metropolitan Life Insurance was insuring their lives, right? So this was also based mostly on white men and women that were insured in the 1930s and 1940s, and hence this term morbid as it relates to obesity. So that's the terms that came from there. So let's move ahead and let's look at BMI and when this term really, really took hold in the 1970s, when Keyes decided to come up with a simple tool. Hey, you guys, let's just put together weight and height. This is simple. This is easy. Height and weight. Let's look at this. We look at height and weight. We can draw some measures and see that, oh, okay, well, this looks easy. And we can determine that this is normal and this is not normal. This tells you if you have obesity. So here we have, right, we have a statistician, and we have actuarial table data drawing to what we now use as the BMI chart to determine whether you are normal or abnormal in terms of size. So I'm going to let you guys determine whether or not that has determined anything about our health status. We then began to utilize these to determine health status. We began to draw population-wide data because it was easy. You heard me say easy earlier. Easy because we can draw population-wide data upon these numbers, and they became the basis of looking at underweight, normal weight, overweight, and then those with obesity based upon BMI classifications that we still utilize every single day to determine one's health status. But I haven't told you anything about your health, have I?
Not at all.
I'll let you guys be the judge of that.
Not at all. There's nothing in that historical perspective that speaks to health. So we're just going to leave that there. We're just going to leave that there.
I agree with you. I've given you nothing about your health. I've given you no health parameters at all.
Not at all. Not at all. Thank you for that, Dr. Stanford, because I think that, it kind of leads us into the next question that I'm going to ask you. Like, how does that play into weight bias that, you and I both are out here, as I say, these advocacy streets, trying to change the narrative around weight bias. But first off, how would you describe weight bias? And do you feel that the use of BMI worsens the problem of weight bias within our healthcare system? What does weight bias look like among healthcare providers? And what steps can we take to improve systemic weight bias?
So absolutely, I definitely think that this rigidity associated with sticking to these BMI parameters augments weight bias. My patients often come into me, and I'm an obesity medicine physician, which means I exclusively treat patients with obesity. But obesity is defined by these BMI criteria. So my patients come and ask me, okay, Dr. Stanford, what am I supposed to be? And I'm like, well, what do you mean? Well, what's the number? What's the number I'm supposed to be? And I said, well, have I ever given you a number? Well, no. Well, you've never given me a number. But, I know you haven't given me a number. What's the number I'm supposed to be? And I'm like, well, I haven't given you a number, so what do you mean, what number am I supposed to be? Well, what does the number say it's supposed to be? They're asking me to tell them something that they know I'm not going to tell them, which is what BMI are they supposed to be based upon what does the number tell them they're supposed to be? Because according to all of what they've been told their whole life, they're supposed to be a number that fits inside of a box that says, based upon what we talked about previously, they are supposed to be this height and this weight, and if they are not that number, something is wrong or they're flawed in some way. There will be an alert that will pop up in my electronic health records that will say, Dr. Stanford, this patient, Jane Doe or John Doe or whomever they are, is flawed in some way because they don't fit in this box, this BMI number. That will then lend to me, if I'm a healthcare provider that's naive and does not know any better, to say that, oh, I need to tell this person something, or they have not done something well enough. Maybe they didn't eat healthy enough. Maybe they didn't exercise vigorously enough. And so there's something wrong with them that I need to tell them to do better, right? And so it augments bias. It reflects more bias, And so this is problematic, right? Because bias is fully entrenched in most individuals, particularly surrounding weight, by guess what, you guys? 36 months of age. I didn't say 36 years. Weight bias is fully entrenched in most individuals by 36 months. So about 3 years of age, we as humans already have significant bias towards those that carry excess weight. So by the time they become your healthcare provider, whether that's as a physician like myself, or as a nurse, or as a PA, or as a dietitian, or whatever, it's so fully entrenched in who they are and the fabric of who they are. And then it's reinforced by our electronic chart that's telling them, oh, yeah, this person has obesity. Oh, it doesn't say it as nice as what I just told you. But yeah, it's telling you that this person is indeed flawed. And let me tell you just how flawed they are, because it's going to give some ugly words. It's not going to use the language I'm using here. And so it further reinforces that the person in front of you, the patient that you're supposed to be providing care for, is problematic. And I'm supposed to tell them just how problematic they are so they can do something about it.
Wow. Dr. Stanford, let's unpack that a little bit, because I'm somebody who's lived with this the entire life. Okay. And so you just struck something in me as you talked about that. And I feel like I have kind of a bird's eye view on both sides, right? Because, I'm a nurse, but I've lived with this, and I have developed.
Nurse Tedder.
Yes. Yes. Nurse Tedder.
Yes, Nurse Tedder.
And Nurse Tedder. Yes. And Nurse Tedder has developed, had to really unpack and still live with some internalized bias because of exactly what you just described. And when I think about...
I was cautious as to how I described it, because I wanted you to see exactly how the system is set up to harm you.
And can I tell you that even to this day, and my history, because I'm very open about it. And that I've had weight loss surgery, and that I still manage it with weight loss drugs, and we'll get into that later. That I have all the things. But do you know that still, when I go to a new provider, I still take a deep breath and still I wonder if they think that, because my BMI, if you go by my BMI, I still don't fit the bill. If we're looking at BMI, I still do not fit the bill. And exactly what you said is still, I have to admit that I still get concerned when I see a new provider that they are thinking, oh, this girl, she, and if they haven't looked at my history, it's like, that's exactly right.
What has she not done well enough, right? Instead of exactly doing what I said at the beginning, right? Or what you said, actually, I haven't gotten a chance to say it, which is to not practice street corner medicine, which is to make the assumption that you haven't done something because of your size. To assume that the person that just happened to walk in their office that was naturally lean because of just the physiologic underpinnings of who they are that walked in, is automatically healthy, right? But I want to talk about the fact that they may be unhealthy because their leanness or thinness may be inherently who they are, or maybe, just maybe, when we talk about medications, for example, that are approved by the FDA, methamphetamine was approved by the FDA for the treatment of obesity in this country for over 30 years. Maybe they just use meth. I don't know. But the assumption is that they're just lean inherently, and we applaud their thinness because we look at them, oh, look at how lean they are. Oh, wow, maybe they ran a marathon this morning. But maybe you ran a marathon this morning. I don't know.
Right.
How am I to make the assumption that the lean person ran the marathon and you didn't run the marathon, when the inverse may be true? So
exactly,
our biases are so entrenched because of what we've learned to believe about body habitus and weight. And it's very frustrating. It's so frustrating. I have to tell this, I'm gonna make this little deviation because this is the frustration that I have to deal with on a daily basis because of how deep my empathy is for this work. I was trapped. I'm going to say trapped because this is how I felt. I was coming back. I'd given a talk at a luncheon for all mostly women, but some men that had undergone bariatric surgery in Orlando this past weekend. Great talk, great group of people talking about what their struggles have been with some weight regain and just helping them understand their biology, et cetera. Very great group. That was not the problem. It was a 10.5-hour delay coming back into Boston from Orlando. So I was trapped, is what I'm going to say, in the airport.
Definitely trapped.
We're going to call that trapped. So instead of me getting back in at 8:29 p.m. on that Saturday night, which is what I thought I was getting in, I got in at 6:02 a.m. And so somehow someone asked me, I guess in this many gates changing, shifting, planes, crew turnover, timing out situation. The wife of this person asked, "Oh, what do you do for a living?" And I kind of explained briefly, just very briefly, what I did. And the husband of this particular wife was, "Well, I've always weighed 175 pounds, and I get up and I do this, and this I. This is what I do, and this is who I am," as if all people are the same, and all of us can naturally be who we are, and naturally be lean, and naturally do this, as if we aren't heterogeneous, as if all of us defend the same set point. And I had to really muster. Like how you've done.
I'm sure it was difficult.
You're like plunging. Think about a plunger, you guys, and you're plunging down like all of your thoughts and emotions, because he said a lot of other things at that gate that I had to really shove down, not to respond. And I said, "Well, that's very great for you. I'm very, very glad your brain defends that set point." Something to this effect, where I literally had to like not say, like kind of explode. Like it was a volcano that was like
it was right there. I know it was right there.
Like could not. And so when people try to say, "Well, this is what I did, and this is because of I, we have to recognize that just because it worked for us, doesn't mean it works for every single person.
That part.
I happen to have a different body habitus from you, but it doesn't mean that you and I are the same people. We were both Black women.
Yes.
We are both descendants of the enslaved in this country. Doesn't mean we are the same human. We are different. My sister and I come from the same mom and dad. Our bodies are different. We were born and raised in the same household. We are very different.
Yes.
And I adore the very fabric of my sister. It doesn't mean that we are different humans. Unless you're an identical twin, I don't expect you to have the exact same underpinnings, undercurrents, signaling that you would expect from someone else. And so let's stop judging other people for how their body works and how that differs from ours, and assuming that they have done something wrong. Let's give each other grace, and let's treat other people exactly how we would want to be treated. And I think if we could just do that, we would be in such a better position. And so when I would listen to this guy go on and on about how amazing he was, and I shoved down every word I wanted to say, because I had so many choice words.
I know you wanted to say "bless his heart," right? Bless his heart.
Oh no, I really didn't want to say that. And the funny thing
in
is,
the Southern kind of way.
I don't use profanity either, and I'm very scholarly, so I had a lot of words that probably would have made him feel quite not so great after the end of this conversation. But it was just we become so consumed of who we are that we forget that there's an entire world of people out there that are not us.
Yes. And
so I think if we just can do that, if we can think of like, gosh, well, let me just try to live 5 minutes in their footsteps.
That's right.
What is their lived experience? Let me just think through what has been their lived experience that reflects where they are today.
That's right.
And if we could just do that, we could begin to change this narrative and the shame and blame game that we continue to hear. Anyway,
that's exactly right. That's right.
My
Well, I think the lived experience, right, and the fact that we as humans are multidimensional, right? It's like this whole thing, this whole concept that I'm wanting to elevate around, that we're more than our BMI. I mean, you did such an eloquent job. Every time I hear you talk about BMI and putting it in its place, I'm like, we're more than that. We're more than one metric. We're more than so many things. And so why anyone would think that it's okay to judge someone based on one thing is crazy to me. So I thank you for that. And thank you for sharing that story so eloquently. And so I'm going to move us into, like, in your experience with patients, and you've talked about this, but what are the biggest challenges that you see in treating people living with obesity. And you do it every day, all day. So what are your biggest challenges, Dr. Stanford?
Yeah, well, there are numerous challenges. Number one is something you brought up actually just a few moments ago, is getting people to understand that they matter. When patients come in and they've been struggling or have lived with, I struggle with using even the word struggled, because maybe they don't feel like they've struggled, because they've been often having this internalized bias towards themselves. They don't feel like they matter.
Mm-hmm.
And I want patients to recognize that they are the most important person in the room when I step in that room. Yeah, I'm the doctor. Yeah, I've been on all these shows, all that stuff. I'm not the most important person in the room when I walk in that room with them. Or if I'm doing a telemedicine visit, I am not the most important person in the room. They are the most important person in the room. And that's a major shift in thinking for patients with obesity, because they've often been told that they don't matter. They've often told themselves that they don't matter, because the world has told them, because of their size, that they don't matter, or they're not as important as someone else. And so that is a major, major shift. And that shift doesn't happen usually at visit 1 or even visit 5. It may happen at visit 15 or 20. And that's huge, right? Because most of my patients have been with me for a decade.
Wow.
Let's say that again. Most of my patients have been with me for at least a decade. And so they may not really completely understand how much they truly matter in that space until we are way down the pathway. But getting them to understand that they are the most important person in the room and that they truly matter, that is the biggest hurdle to overcome. So that's my biggest challenge. Okay. So
but see, I think that speaks to, but see, you are kind of, I'm going to say, a unicorn in the space. And what I mean by that is you are a healthcare provider who is truly committed to building relationship. And I know that we've been on panels together, so you've heard me say that one of the game changers for me in my journey was that after kissing several healthcare provider frogs, as I say, I found a healthcare provider who was also a unicorn, who I was with for a long time, and she built a relationship with me, and it was the trust, because that's what you're talking about. She had built trust with me, and that is what helped me to get to the point that I was open to putting more tools in the toolbox, like surgery, medication, all of those things, right? Because I too had succumbed to the bias and all of those things. And so you are absolutely right. When you are me as the patient living with this, and you think like, well, people don't see you. They don't see you. They're not listening to you. They don't hear you. It's like all they see is, oh yeah, you're probably like eating like a bag of Oreos every day, and you're not. And you're like, I really am out here exercising. I really am out here trying to change my diet. I really am doing all the things that you're telling me, but most people don't believe that's what you're doing. But when you find that provider who sees you, who validates you, who talks to you like you're a person, and who really partners with you, that is the game changer. It really is the game changer, because up until you get that, nothing else really matters, because you don't need your healthcare provider to blame and shame you. You're already doing that yourself. You're already doing that yourself. So I think that is that's
the biggest barrier. It's huge. And I think it takes a long time the reason why it takes you to find the unicorns is because we really are those people. I mean, there's so few of us that really, truly, genuinely believe this. You should see how much time it takes for me to work with even healthcare providers, or how many times I'm fixing healthcare providers, physicians and Ps, PAs, et cetera, in the middle of a call or middle of a conversation. And when I'm like, no, you need to change your language. They're like, oh, it's just us. And I'm like, no, I don't care if it's just us or whatever. Are you going to call me a negative name because of my race as soon as I walk out of the room? And they're like, oh, Fatima, why would you say that? And I'm like, oh, okay, well then do the same thing in this situation, right? The same thing applies, because I would talk the same way regardless of who's in the room. You don't change the language just because the people are here or not here or whatever. The language should be consistent throughout, right? We should be talking in a positive way consistently. So I would say the hardest thing is the thing that I mentioned. But I think the key thing is also having people to recognize that when we're dealing with this chronic, relapsing, remitting disease, that it is indeed just that. That this is a long haul. This isn't like, a lot of times, especially if I'm doing interviews for whatever the media outlet is people like, oh, hey, so, okay, so you put them on medicine, it's like a magic pill. This is not magical. There's no magic. This isn't.
No, there isn't.
For the cameras. I mean, yeah, I'll get in front of the camera, but I'm going to tell you the truth. This isn't, there's no magic behind this. The new medicines aren't magical. Surgeries aren't magical. This is a chronic disease that we're treating, and there's no glamour or glitz to this. There are some patients that will respond in some way, and some people respond in another way. But this requires work, this requires dedication, and this requires long-term commitment. And if you want an answer that's anything different than that, then you need to interview someone else, right? That's what I tell them, and I'm sorry if that's what you're looking for. I'm not your girl. And so, and then with my patients, I tell them that, like, if you're looking for someone that you just want to come in, get something quickly and go look cute on South Beach, I'm not the person for that. You need to find another doctor. I'm not that person. So it's okay. You can find someone else. I'm not worried about having patients. There's a lot of people waiting to see me, so I'm not worried if you need to find someone else. I'm here for the long-term commitment. So if that's what you're looking for, someone that's going to be here with you to guide you through the ups and downs, because they will come, then I'm that person, okay? So that's really how I think about it.
No, thank you for elevating that, because that's true. And when I talk to people, I say the same thing. When people are like, oh my gosh, like, is that like, did that change the game? I'm like, actually, like, as you can see, I'm not wasting away to nothing. Okay. That is not how this works. And I'm like, if you are not in it for the long haul, you don't want to do any of these things, because it just doesn't work that way. That's not how it works. You have to be willing to do the head work, the heart work, the spiritual work, all of those things. And it's not a one and done, right? Yeah. It's all of that. So that's what I think. In terms of the provider-patient relationship, what should patients do, Dr. Stanford, if they feel their provider isn't listening to them? If they feel, because there you go.
It's time to go. It's time to go. I mean, I really, I know that it's. You feel like, okay, wait a minute, there's not enough people. But if you can't work with that person and that person's not willing to work with you, is that going to change tomorrow? I mean, all of a sudden, are they going to wake up and have some revelation? The likelihood that that's going to happen is slim to none. Unless they come and listen to a lecture of mine and are radically changed. I'll give one example where that happened. I don't think this happens often, but I was actually at a convention or at a conference, and I don't know which conference this was, pre-pandemic, how everything is delineated, before the pandemic or after the pandemic.
Yes.
And I had just given this lecture, and there's usually this line of people that are waiting to talk to me after I give a talk. And finally, this woman gets to me and she's crying, and I'm like, oh goodness. Nurse Tedder, I'm like, oh gosh, what did I do? Did I say something? I was like trying to think through my lecture. Did I say something? I usually am very cautious about what I say, and I think I say use my right language. And so she's crying. I'm like, did I invoke this emotion in this lecture? And she's like, so I get to her cautiously, right? She's the last person in line, and I'm like tentative, right, about speaking to her. And she says, no, Dr. Stanford, I'm here to thank you. But she's crying, and I'm like, this doesn't seem like a thankful situation. She says, no, I'm here to thank you because you gave a lecture a year ago that my physician went to. I had been trying to get him to use anti-obesity medications, and he would not do it. She had liked this physician and had been going to this, I guess this had been her doctor for 7 years. He listened to your lecture, he listened to you give this lecture last year, began me on anti-obesity medications. I've lost 72 pounds. So I found out that you were speaking in whatever city I was in. I have no idea what city I was in at that moment. And I just wanted to come. I registered for this meeting to come and thank you, because he wouldn't listen to me, but he heard you speak last year at whatever this meeting, some other meeting. And because he listened to you, he started me on medications finally, and I'm down 72 pounds. So I say that typically people will not radically change. I have no idea what lecture I had given a year before at whatever meeting, but something I said to this, whoever this guy was, no idea which physician this was, changed. And overnight, he changed, and this patient was coming to tell me, thank you.
Oh.
So I'm thankful that I told you I'm a woman of faith, and for me, Christianity is my faith, and so I think God gave me this gift to be able to change minds. I have no idea who the doctor was. I can't remember who this patient was, but this mind was changed. It changed her life. So when I go and give a talk or a lecture, I give about 150 of these a year. I have no idea whose mind is being changed. But in this situation, this one doctor who probably treats, let's say several thousand patients a year, had an impact. And this impact for this one patient mattered, but I'm assuming that he probably had an impact on several other patients. And so
that's right.
While I can only treat a small number of patients as an individual, right, I'm rate limited in the number of patients I can treat as an individual physician, maybe, just maybe, and we're going to say that possibly, I can have an impact on a larger number of patients. And to see her coming in, crying, not crying sorrowfully, but tears of gratitude, that has an impact. But individually, typically, unless they happen to have heard whatever lecture I gave, I have no idea even what lecture that was, you're not going to have these radical shifts, right? And so you need to find someone that's willing to work with someone in a compassionate way.
Yes. But Dr. Stanford, that's a beautiful story. And I believe that if one person changes, because that exponentially, his practices change because of that. If she was impacted, that means that other people that he or she are treating is impacted. And that's why I do this work as well. I also have a Christian faith and believe that the more that our voices are heard, and that's what I want our listeners to know too, is like, listen, your voice does matter. And so the more that we use our voices to advocate for what is right, like what we're doing here, that if one person is impacted, then we have done our job, So I know we were going to church today, but it's okay. That's what we're doing here.
Going to church.
It is all good. It is all good. Yes. So I want us to make sure that we talk about the anti-obesity medicines, because it's all the rage, and so there's a whole lot to unpack, and I definitely want to make sure that we touch on it before we finish up. And I also wanted to kind of do a pretend case study, because I want people to walk away with your expertise and your brilliance. But talk to us about the anti-obesity medications, because there's a lot of things about it. They certainly are game changers. They certainly are tools in the toolbox, but you and I both know, again, there's no magic bullet out here. And there's also concerns about access. There's concerns about misuse, all of that. So I want you to speak to this, because, as far as I'm concerned, you're the most trusted voice in the space. So talk to us about it.
So I actually don't ever use the term game changer or, magic bullet or any of those terms. The reason I don't is because, not everyone are responders to these agents. But let's talk about anti-obesity medications. And I want to give a little bit of historical context. First of all, there are several medications that are approved for the treatment of obesity currently in the United States. Some of the medicines that we do use have been around since 1959, so quite a few years ago, before I entered this earth. And so, but the medications that we're hearing a lot about fall under this class of medications called GLP-1, which stands for glucagon-like peptide 1 receptor agonist. Say that 5 times fast. I don't think you'll be able to. But these are the medications that have been getting a lot of attention. Some of the historical medications don't fall in that class. It's important to note that almost all of the medications are working centrally. What do I mean centrally? In the central nervous system, which is the brain, this lovely organ here that controls all the things that we do. both consciously and subconsciously, but most of them are working on our, unconscious brain, right? They're working on pathways of the brain that control food intake and weight regulation and control how our body controls or regulates adipose, okay? So adipose is this fancy word for an organ called fat, okay? So the GLP-1s do work to upregulate a pathway of our brain called the POMC, or the pro-opiomelanocortin pathway of our brain. That's our anorexigenic pathway of the brain. And they work to down-regulate our AGRP, or agouti-related peptide pathway of the brain, which is our orexigenic pathway of the brain. The reason why that's important is because this is our primary pathway of the brain that regulates food intake. And this is why these drugs have become more popular, is because on average they lead to greater weight loss, because that's the primary pathway that regulates food intake in our brain. Now, these medications are primarily given by injection, mostly on a weekly basis. We do have single agonists, which means these are medications that will just work on that pathway. And now we have what we call dual agonist drugs, which means there are GLP-1s, and they also have a new agent that combines a GLP-1 with a GIP. A GIP stands for glucose insulinotropic polypeptide, where we have two agents working together. Now, it's also important to know that all these agents we're talking about aren't just injectables. These things are already housed in our gut. So GLP-1 is already in our gut. Some of us just have more of it than others. GIP, which is that glucose insulinotropic polypeptide, already in our gut. Some of us have more than others, right? So when we're giving it to some people, we're augmenting what they already have inside of them, but some of them just don't have as much as others, okay? So we're augmenting those that don't have as much. For those newer agents that we have on board, semaglutide, given under two trade names, Ozempic and Wegovy. We hear a lot about Ozempic. Ozempic is the trade name for diabetes. Wegovy is the trade name for the treatment of obesity. It's the same drug, you guys, same drug, same drug, same drug. The agent is semaglutide. So the agent is semaglutide, Ozempic is semaglutide, Wegovy, semaglutide. Wegovy for obesity, Ozempic for diabetes. Same drug, okay, you guys? Got it, all right? Now that dual agonist is the tirzepatide, okay? Tirzepatide is the agent, Mounjaro, Zepbound. Mounjaro, Zepbound is tirzepatide. That's that dual agonist, okay? So these are both injectable agents. Now, we've had medications, like I said, that have been around since 1959. Phentermine, for example, has been around since 1959. That works in a different pathway of the brain. It inhibits something called norepinephrine within the brain. Topiramate, approved in combination with phentermine. It does something like stimulating GABA, that's gamma-aminobutyric acid within the brain. Bupropion and naltrexone, approved in combination for treating obesity. These are different agents, all working mostly in the brain to treat obesity. So we have a lot of different agents that we can potentially use, and more are coming about for the treatment of obesity. So that's a lot. I'll stop there because we can get into even more details with drugs like orlistat, which have been around, some available over the counter in your local drugstore, available also by prescription. That gives you kind of a good solid understanding of what's available in the United States.
So in terms of treating your patients, what kind of barriers do you run into with folks accessing the medications? How has policy come into play?
Well, a lot of issues. Number one, insurance coverage. Some of these medications can be very, very pricey, particularly those injectable agents. They can range somewhere between $1,200 to $1,600 a month, not a year, a month, right? So that's very, very exorbitantly priced. If you don't have the right insurance plan, that's very, very expensive, right? That's more than most people's rents or mortgages a month, unless you live in Boston, where it would only be a fourth of your rent or more.
Right.
Right. Trust me.
Yes.
So that's very, very costly. And so if you are a Medicare beneficiary, unless you have heart disease, which now they do approve it if you have heart disease, that's a recent change in Medicare policy, where if you have heart disease, this just happened within the last week, that if you have Medicare and you have heart disease, they now cover it. But previously Medicare had zero coverage unless you had diabetes. So So now
Yes.
diabetes and heart disease now have coverage. But if you have just obesity, which a lot of people do have, no coverage. If you are under Medicaid, unless you're under specific Medicaid plans that do cover this, no coverage. Unless you're in the top tier of most healthcare plans, no coverage. Access issues, very important. You asked me that as a question. Certain players like Novo Nordisk have run into major shortages for the last year and a half. I have had major issues with getting coverage for semaglutide. Remember, that was that Wegovy,
Yes.
the treatment for obesity. Those lower tier doses, there are 5 doses of this drug, 0.25, 0.5, 1.7, and 2.4. Almost nearly impossible to get the first 3 doses. The maintenance doses of 1.7, 2.4, not as challenging to get. So these are major issues that we're running into with these agents.
Yeah, it has been a challenge. I actually had been caught up in that too, and recently was switched to Monjaro and haven't, knock on wood, haven't had any trouble getting it. But yes, these are challenges when you're building your treatment plans, right, for your patients, and people do need to know that. And the insurance coverage is a big deal, because I think it's only 16 states that have some sort of Medicaid expansion plans that you can choose to even get coverage for these medicines. So another reason why our listeners need to be educated about it, why people need to be advocating and talking to their representatives, their policymakers and officials, right, that we have fair and expansive coverage for obesity care, right? So it's really important.
And
I'm
speaking
sorry, go
to
ahead.
that, right, we've been trying to get the Treat and Reduce Obesity Act across the House floor for over 12 years, you guys.
Yes, ma'am.
12 years is a
12
long
years.
time. And so just to talk about what that bill would do is to get coverage under Medicare for 2 major things. Right now, it's to get behavioral coverage. Right now, if you have, for example, obesity and you're a Medicare beneficiary and you want to meet with your dietitian, for example, to do meal planning, things of that sort, if you have obesity, no coverage. You would have to wait to get diabetes to be able to meet with your dietitian to get that visit covered, which seems problematic to us. Similarly, coverage of anti-obesity medications with obesity, no coverage. So we still would love to get that bill across the House floor. No, ability to do that as of yet. I think last time we checked, it was maybe 120 co-signers in the House. So really, really eager to get that across, but 12 years unsuccessful getting it across the House or Senate floors.
Yes, and so it's important. So that let's just be clear. So as our listeners are listening, why we need their voice is because we preach and teach you have to have comprehensive care when you are treating obesity, right, Dr. Stanford? So when you're telling your patients, hey, if we're going to prescribe medication, we're not just going to prescribe medication. We want you to have nutrition counseling. We want you to have behavioral health care. We want you to have access to everything. And so that's why our voices matter. That's why we have to raise up advocates. That's why we want you talking and sharing your stories, because that's what matters. And that's how you get what you need to have comprehensive care to treat this. So I'm always going to be elevating that conversation here. But Dr. Stanford, I'm going to read this mock case study for you, because I want people to kind of have an idea of how you do your work, because you do your work. You do your work. And so I just want to know how, and I want providers also who are listening to this to just know how you do your thing, and to give people some ideas. So a 36-year-old female comes to you reporting that she is concerned about her recent weight gain. 6 months ago, she started working out with a trainer 4 times per week for 60 minutes. She has been eating a clean diet with fruits, vegetables, lean proteins, and drinking lots of water. She does like to drink alcohol on occasion, but she has been limiting her consumption to 4 to 5 drinks per week when out with friends. Her starting weight was 178 pounds, and after training for 6 weeks, her weight dropped to 172 pounds. In the past 6 weeks, she has gained almost 10 pounds despite maintaining the same diet, drinking less alcohol, and working out 3 to 4 times per week for 60 minutes. She has been under a lot of work stress and notes that she has a history of mild symptoms of PCOS. Symptoms include hair growth, heavy periods, acne, poor sleep, headaches. Previous providers have often suggested eating less and exercising more, which is frustrating and insulting, given that is what she keeps doing with minimal results. Her BMI is 34. How would you approach this patient? What diagnostic tests might be helpful? What should patients do if they encounter this with their provider and they're not listening?
Yeah. Well, thank you for sharing this. Well, first of all, this woman seems like she's done a lot, and she's struggling, and she has this PCOS, and she has this resistance. So she probably has some insulin resistance associated with this PCOS diagnosis, and she's very, very frustrated. I would do, first of all, a full workup with her. And I think it's important for us to make sure that every single patient that comes in gets a full diagnostic workup. So first of all, and my patients know this, and anyone that's tried to see me that thinks they're going to come in without a full laboratory assessment knows their appointment will be canceled, because I can't practice street corner medicine. I need to do a full assessment, which is going to include a comprehensive metabolic panel, right, where we're going to look at all of your fasting, blood sugar and things of that sort. I would love a fasting insulin level. I'd love to look at your lipid panel. I want to know what's going on there. I want to look at that hemoglobin A1C. I want to get a sense of, also I want to do a deeper dive into some of the family history. I want to look at some reproductive health parameters. We don't know any issue of that. We're getting into that kind of advanced maternal age. We don't know if she's, trying any fertility treatments. There may be some things going on in that domain that we don't know about, that we need to really be keenly aware of, particularly as we're transitioning in that post-35 realm. I want to know if there's any herbal supplements that she's trying. This is a very common theme in this 35 plus realm. And make sure I'm not missing anything from that perspective. I'm going to get some better information about her sleep. We heard some kind of disruptions in her sleep and sleep quality. Are we possibly missing obstructive sleep apnea, which can cause some major issues here? So I'm going to do a deeper dive into her. And then, if needed, and it sounds like she's going to need some type of therapy, she may need anti-obesity medication. She may even need surgical intervention, believe it or not. If she has any metabolic disease, the American Society of Metabolic and Bariatric Surgery changed their parameters and cutoffs for surgical intervention at the end of 2022, such that surgery is now considered for persons with a BMI of 30 to 34.9, which is a major shift from their guidelines that were in place from 1991 all the way up to 2022. But as you guys know, we're in 2024. So I'm looking at a full parameter of what this patient may need and what also the patient is willing to consider, right? So it's not just what are all the options, what is the patient willing to consider? What is she thinking in terms of fertility? Is she looking at potential family planning at this point? I need to hold the whole parameters of what she's looking at. If we're looking at anti-obesity medications also, and if she's thinking about family planning, we need to know that if we're using the GLP-1s, we need to stop those medications 2 months prior to conception. If we're looking at like phentermine, we can stop that immediately. Topiramate, I would like that out of the system about a month or so before. We need to look at forms of contraception because of the risk of birth defects with medications like topiramate. So I'm thinking about all of these things in a woman that's 36 years of age. And so, yeah, that's how I'm thinking.
Wow. Thank you. But you took such a comprehensive approach and thought process. You didn't look at this patient from just a vacuum, like, yeah. And many providers do that. It's like, oh, you're 36, you're healthy, you're doing all the things, just keep doing it. And so many times that's what happens when people come into a provider's office, So I thank you for that, and for just kind of giving us a little mock, practice around.
I'm like,
how,
blah, 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 blah.
Yeah, but I think that providers need that, So I just thank God that you're in the space and that we have your voice, because we need so many Fatima Cody Stanfords. We really do.
Oh, yes.
If we could clone you, it would be so amazing. It would be so
if you could clone
amazing.
Me so then I can get some rest too, that'd be good. Yeah.
Yes, that'd be great.
Can I get one?
That'd be great. We'll work on that. We will work on that. So one other, maybe two other questions I'll ask you, but what are the consequences from your standpoint? And you've kind of talked about it a little bit, but what are the consequences of poor patient-provider relationships as it relates to the treatment of obesity?
So if you have really poor patient-provider relationships, I think this sets up a really negative cycle such that the patient won't come back. When the patient doesn't come back, that sets up poor health outcomes for them. I think that actually the negative health outcomes that we see on the patient side is poor treatment adherence, because there's no need for them to adhere to any treatment because they're not going to come back to you. I think the rise of the fat acceptance health at every size community is actually born out of poor treatment from healthcare providers, whether they be doctors like myself, whether they be nurses like yourself, or NPs or PAs. If you've received such maltreatment within the health space, why come back to see us? I mean, this is a torturous environment. It's a malignant environment. It's not a safe space. The place you're supposed to go to get comfort and care is a place that's provided discomfort, and feels like a place where you're going to face your most resistance. And this is, I think, really where the creation of those communities have come from. And there is unfortunately, a black or white that all healthcare providers fall within that camp of being malignant. And this has set up a situation where only at the very end of life are we seeing these individuals seeking care often. And it's where things are often at the end stage, right? So because there's been these delays in care, because I don't need any care, I'm healthy at my size, and you can't be healthy at different sizes. I do agree with that. But if we don't do any investigation, like I said, we can't practice street corner medicine. We still need to do a dive. And yes, you can be healthy at different sizes, but we don't know that until we've done that investigation, right? So I think that's problematic. And if you have that relationship that's not balanced, not supportive, not equitable, you're going to run into that situation.
I agree. Well said. So as we begin to wrap up, I'm going to put this out there. How would you complete the following sentence as it relates to someone entrusted with the care of a person living with obesity? Dear healthcare provider,
please treat me with respect and grace. I matter just as much as anyone else.
I love that. And on that note, we will conclude this inaugural episode of Dear Healthcare Provider. And I'm wishing all of my listeners joy, peace, and good health. Thank you so much, Dr. Stanford, for this rich conversation.
Thanks so much for having me.